So thank you for joining us today for our policy committee meeting. My name is Amelia Boyd and I am the program manager for the Medical Commission. If you would like to speak during this meeting, please use the raise your hand function and we will call on you. And Christine Blake is the chair of this committee and I will let her get started. Let me share my screen, which has the agenda.
Thank you, Amelia. Do we have some outside folks joining us? It looks like it might be us right now.
No, we have several.
Oh, we do.
us.
Okay. All right. Wonderful. Thank you all for coming. As Amelia said, I'm the chair of the policy committee. Thank you for taking the time out this afternoon on a beautiful day like this to join us in our policy committee meeting. Amelia has our agenda up. Our first item is call for volunteers for a small work group for the medical marijuana authorization guidelines. As you can see from the agenda, these volunteers will work with DOH to review and update the medical marijuana authorization guidelines, identify needed changes, ensure clarity and consistency, and recommend updates based on current best practices and regulations. Amelia, should folks reach out to you if they're not sure today?
So I think I'm not sure who of Micah and Kyle who were going to present this one actually.
I can go. I was involved with Dr. Harrison. So the last time this came about, this is a regular review, and DOH updates these, and generally we will adopt them as just the new standard when this happens. The last time it was Dr. Harrison, a pediatrician, who against our advice, he moved to Hawaii, so he couldn't be on the commission anymore. But so he's doing a hardship tour over there. So at this point, just for clarification, this is a call to commissioners to serve on this. It's a appointee work group, and so at that point, I think yes, if Amelia is okay, then we can have volunteers contact Amelia. Otherwise, we can do it another way.
You okay with that, Amelia?
I wanted to ask Amelia about the process. Would we send out a note to all the commissioners and maybe have with it the current policy so they could see what they're dealing with and get that feedback?
Sorry.
Go ahead.
This same agenda item will be on the business meeting agenda for next week, and the same documents will be included and the same ask will be included. I will clarify that it is for commissioners and not for just anyone in the agenda for the business meeting next week, but they will be able to see all of the documents that you're seeing here today.
Good.
Okay, so
I was wondering if we would consider a non-commissioner along, I don't know of anyone I want to name, but with some expertise in this, especially with pediatric marijuana use. I don't know, someone like Chris Bundy or someone who'd have some experience with current experience with marijuana would also be a good addition. At least in an advisory role.
I think we would need to get some clarity from DOH on what they're looking for on that work group. This is really just us supplying someone that we would like to sit on it, and it's not our work group to control. So we could certainly, I'm not sure who our contact there is, but we can certainly find out.
So this will be led by the Department of Health?
Correct. This is about every 4 years, I believe. So it's when they do this. It's just because they want to try and have a consistent standard among the various professional regulatory boards. So they try and do something a little bit centralized, since at least when it first came about, there was not a lot of data to be used with respect to how do you assess and say, I will authorize this in a medical context clinically. And so they brought a group together to try and bring forward the best that they could. Dr. Harrison notably insisted on and was eventually successful in mandating inclusion of consideration of pregnant and pediatric populations.
Yeah, but it's a different, whole different topic in adolescent, certainly medicine.
Yeah.
Okay, so DOH, if they would like it, could bring in some expertise as well.
I'm happy to volunteer Dr. Bundy for anything that he can't stop me from volunteering him fast for.
Okay, great.
Okay, thank you. Anyone else have any comments about this? If not, I'll move on to the policy for practitioners exhibiting disruptive behavior. This is again another 4-year review process. And we did have some outside comments that were sent in. We've had a chance to look at those as well.
Sure. So I'll just, if you don't mind, Chair
Sure.
Blake, I'll just jump in. So you're correct. This is a standard review and update. And I will say, with respect to the WSMA comment, I do believe that it does come from a well-intended place. I will say, with the caveat, there's quite a bit of nuance both in the origin and application of this policy. So without going into too much detail, I will respond to a little bit of it. So basically, the definition of disruptive is not subjective in this policy, nor is it subjective in the research and case law that we cite as the basis of this policy. It's quite specific, and specifically, it makes clear that it's disruptive behavior is rooted in what's considered is not rooted in what's considered a culturally appropriate or non-appropriate behavior. And it's closer to a diagnosis when it comes to pervasive and ongoing behavior. Specifically, it discounts one-off behaviors in the policy itself. And importantly, and I would say most importantly, the definition of the behavior cited, they have to have a direct link to the disruption of safe patient care. So it's not just behavior in itself. It's not someone raising a concern. It's not someone advocating for themselves. It's persistent, ongoing, presents a risk to the system and the safety of the patients. So, the other piece is the implicit bias. I just want to highlight. I totally respect what's being suggested there, but I will just say that this is something that we've been doing for years. And so for the benefit of the group, we have an equity and social justice manager who has been attending your case management teams for the better part of, I think, 2, maybe 3 years. And she is empowered to speak directly to you to raise bias issues that might be present in a complaint. I'm sure you've seen some of them. She also does research briefs that cite data and highlight relevant bias issues that may be present in the complaint before you. And so you've seen that, you've all experienced that. So that DEI step is actually much more robust than what's being suggested here and is a normal part of our process. It's just not part of this policy. It's included in our discrimination in healthcare policy. It's included in our CMT procedure. So I just wanted to make sure that everyone was aware of that. And with that, I would recommend that we consider leaving the policy unchanged to go forward. There's not been a significant update in the research or change in what we've done. And notably, every time that we've applied this policy, it has been to a male physician.
Thank you, Micah. Amelia, I can't tell if there's anyone outside that maybe has a hand raised or wants to comment on this. Okay.
So if anyone would like to comment, go ahead and raise your hand. Go ahead, Hillary. Let me unmute you.
Megan, thank you. Oh, sorry. Hillary from Northern Washington State Medical Association. Micah, thank you so much for responding, and I will pass that information on to Jeb and also to the members who kind of raised those concerns driving the comment letter. So thank you.
Not a problem. Thank you, Hillary.
Dr. Lyle?
I was just going to say I appreciated the comment, and I didn't know if we needed to add to explicitly to the policy that the discriminatory safeguard or help or whatever support we have in our process, you need to explicitly say that in the policy. Or if I was going to say to reach out to WISMA and say, yes, this is baked in. We already do this. And the other thing about changing the title of the policy, I'm not big on that stuff, but I did look at some of the resources cited in the article or in the policy, and it is that is the nomenclature that's used, is disruptive physician. And so I think it's consistent with the data and the articles and research that are out there regarding this topic. So I just wanted to say those two things.
Thank you, Dr. Lau. I agree. That is the language that's also used in hospitals and facilities in their policies. So it is the word disruptive is used pretty extensively.
And I just wanted to ask Micah, that last statement you made that they're all male, can you tell me the significance of that statement? I'm not sure I'm following what you were meaning to communicate.
Sure. So the WISMA letter raises specifically that women and communities of color may be unfairly or unequitably having this policy applied to them for the act of cultural differences or the act of speaking up and advocating for themselves in a medical setting. And so the reason I bring that up is because, so the research that's cited here in the WISMA letter that you see linked is actually a focus group study of 28 self-selected women who attended a specific conference, and it addresses the advancement of women through the House of Medicine. And while it certainly speaks to the equity issues that are associated with that, whether it's someone who's just starting out or it's someone who are later in their career, they've got leadership or something like that, that's not really on point with what we're dealing with in this policy. In this policy, we're dealing with a pattern of behavior, and there's a way of assessing it. It's either someone who has a condition to treat or someone that doesn't have a condition to treat, and the ones that don't have a condition to treat are far more difficult to remediate. And so that actually was the genesis of this policy, and it came from the mind of a CMO who, as they were developing it, they basically said every CMO in this state has in their office a file folder of one particular practitioner in their institution that's this thick, and they haven't been able. And I see Ms. Blake smiling because she knows exactly what I'm talking about. And they just haven't been able to get rid of them for one reason or the other. There's an organizational risk, there's a lawsuit risk, what have you. And so there's the attempt to remediate them or at least contain that behavior in the institution. Sometimes that spills over to WPHP, and WPHP reports them to us or says we don't have anything to treat here. Sometimes it results in a complaint, and then that's when we get involved, and that's when this policy would apply. So it's not someone advocating for themselves. It's as I said before, it's pervasive, consistent behavior that results in a risk to patient safety.
Thanks.
That's
helpful.
Yeah, Kyle has his hand up.
Thanks, Ms. Blake. Dr. Prescott, I was just going to add, and this is anecdotal, not supported by, we haven't done a deep dive on data or anything, but there does seem to be a generational aspect to the overall concept of disruptive behavior and conduct by physicians. And we are seeing again, anecdotal, we're seeing a gradual lessening of complaints that are referred to us. I won't speak for, obviously, hospital administrators like Ms. Blake, but at least at the Medical Commission, we're starting to see less of it. And I think that reflects maybe the fact that about, 15 years ago or so, there was a big push to kind of address this concern within the physician ranks. And so, again, as I think the House of Medicine has kind of evolved, we're seeing less of these complaints, just for the record.
Yeah, I think I can remember about 10 years ago, the Orthopedic National Association saying the era of the cowboy physician is over. So they really were taking a strong stance on that and trying to address it.
I would say there are disruptive physicians who are female. out there. They may not get called to our attention, but although maybe all the complaints we're aware of are male, I don't think that that's always true.
My point, Dr. Trescott, is the things that we've taken action on are males.
Okay. And that makes sense. That there'd be a preponderance of men.
Any other comments or questions or hands raised that I am not seeing?
I don't see any other hands raised either.
So the request is to not change the policy and to leave the language as is. I need a motion for that, please.
So moved.
Second.
All in favor? Aye. Thank you. Our next is a guidance document on medical professional, is a procedure for interactive and transparent development of evidence-based policies and guidelines.
Thank you. So on this one, Ms. Blake, I'm going to ask for a deferral because your new policy manager is starting May 16th, and I would like for her first assignment to be to go through this and propose any changes that she might identify through her experience.
Okay, thank you. We'll defer it then to our next meeting.
Thank you.
Sure. So then our next document is the guidance document on medical professionalism, and it is also a scheduled 4-year review process. Did you want to make any comments on this, Micah?
Yeah, on this one, we received the WSMA comment, which speaks to some aspects that I think probably should be considered by the committee. Unfortunately, we received one last night, and to the last person, between Kyle, myself, and Amelia, it landed in our junk email for some reason. And so I didn't discover it until I was on with Amelia, and I just happened to find it in my junk email about 10 o'clock today. So there, I think between the WSMA comment and the P3 Alliance comment, there are some things that you probably might want to consider. If you feel differently about the comments and you think it should go forward as is, by all means, exercise your judgment. But there do seem to be some fairly common sense updates that could be applied here.
I agree. I thought the WSMA comment was good and could flesh out a section, and I was trying to figure out where to put that. And then I think that the P3, is that what it is? Comments were also really valid, but I wasn't sure how. Anyway, it takes some wordsmithing to get that go in there, but I thought it had some very good points as well. So.
Do you think this needs to be looked at a little bit closer before we move forward with it, or are you on to the board?
I would suggest that we defer it and let the new
Yeah.
policy manager take a crack at incorporating some of these, especially when it comes to things like social justice and unconscious bias. This person has some lived experience that's going to be relevant.
Agreed. When I saw these comments, when I read these all, I thought this might need to be deferred for a little bit more review.
Yeah.
Okay, so then we'll also defer this this one as well. Let me see, I have my.
So will we get access to those comments that you just recently received, Cal or Micah?
You have access to them now
We
in
have
the
them.
packet.
Okay.
But you'll also have access to them as they come back to what I assume is going to be an interested parties meeting. Amelia, is that right? Okay.
Correct. Yes.
Yeah, so it'll come back to an interested parties meeting and then come back to policy. And if you approve that, it'll go to the business meeting.
Great.
Okay, thank you. Then we'll defer that document as well.
You have a hand up, Ms. Blake.
I'm sorry. Oh, okay. I'm sorry.
Oh, sorry. Hillary Norris with the Washington State Medical Association. Thank you so much for considering our comment on this guidance document. I'm not sure if now is the time to share more substantive comment or if I should wait till the interested parties meeting.
No, go ahead.
Okay, thanks. So we had a chance to review the comments submitted by P3 Alliance, and we appreciate and are sympathetic to the issues that patients have been having in accessing pain treatment. We just want to raise that WMC has done a lot of work in this space in separative interpretive statements that we've supported. And we just think for the purposes of this document, it might be helpful to just focus on just a clean statement on medical professionalism rather than a specific condition or patient group. So thank you for considering.
Thank you, Hillary.
Thank you. Did I miss anybody else, Amelia, that you can see?
Anybody.
Right, okay. Thanks for pointing that out for me, Micah. Our last document is the joint guidance for retail IV therapy clinics. Did you want to discuss
This
that as well?
one, I think, is Kyle.
Oh, Kyle. Okay.
This one, I hope, is Kyle.
Actually, Micah, I'm going to ask Mike Farrell to talk about this one.
Awesome.
This is a result of a long-running work group that coordinated. Mike, as well as Dr. Fino, were involved with, frankly, more than I was. So, Mike, the floor is yours.
Okay, thanks, everybody. Mike Farrell here. The commission formed a work group amongst several staff members, including Dr. Fino, but also including 2 commission members, Dr. Murphy and Dr. Jager, to tackle this problem about IV hydration clinics popping up and unsafe practices occurring within them. So we looked at what other states have done, and we found several really good position statements done by other states. And some of them were joint statements among the medical osteo boards and the pharmacy boards and the nursing boards. And I found a good one from West Virginia. So this is acknowledged in the first footnote, the 3 boards that really did a nice job here that I borrowed heavily from, especially West Virginia. So the work group liked this. I have shared it with the Washington Board of Nursing. I've shared it with the Pharmacy Commission. I've shared it with the Board of Osteopathic Medicine and Surgery. I received feedback from the Osteo Board that looks good. The Pharmacy Commission is meeting on May 22nd to discuss this, so I have no feedback from them. The Nursing Board is meeting next Friday, same day as us, to discuss it. I did get feedback from 2 of their staff, nurses on their staff, that I'd like to go over with you, if that's okay, just a few little comments.
Sure.
Amelia, if you could scroll down to the introduction portion. There is a lengthy introduction portion. It's several paragraphs long. I got this from the West Virginia position statement, and the nursing staff is recommending that we remove it. It is a nice description of the problem, but it's probably not necessary for a guidance document for licensees.
Mm-hmm. I can see why they would say that, to take that out after reading this.
If you take it out, you start with a statement of the problem and then you go right to the advice.
Mm-hmm.
So for busy practitioners, that's probably what they prefer. It's a nice statement of the public about what the issue is and how this
Right.
all operates, but I wouldn't mind if you took it out.
Yeah, it's more like a public service announcement than it is a intro.
I mean, I think it's interesting that it explains the scope of the issue, but yeah, I agree. It doesn't need to be in this document.
Okay, and then if you look at number 1, under legal requirements and best practices, it says the services provided in an IV therapy clinic, the diagnosis of the patient's condition and the recommendation of IV therapy constitute the practice of medicine. They would like to add and advanced practice nursing.
Don't
The idea-
advance practice nurses practice medicine?
Yep. Are they, you mean like the NPs, nurse practitioners?
Are they practicing something different?
You mean than this is why to call them out?
Yes, to
Well,
say that in
yes.
an IV therapy clinic, advanced practice
Mhm.
nurses can diagnose and make a recommendation of IV therapy.
Right.
So they didn't want this document to be read as just allowing MDs and DOs to do this.
Yeah, I agree with adding that in to make it clear. Because somebody can come back and say, well, a nurse practitioner did this and this doesn't address that. Dr. Lyle,
I don't understand because you're talking about medicine in the generic medicine sense, not medical professionals. So if advanced practice nurses do something other than practice medicine, then I think that's valid, but they don't. They practice the same, their scope is the same. So I think that the word is not meant to indicate providers. It's the practice, the art. That's how I
Yeah.
read it.
Amelia, can you scroll up to the first page? And the first page defines, excuse me, practitioner at the bottom of, or near the bottom of the page, right there.
Yeah.
oh, it says nurse practitioners.
Yeah. I mean,
So then, yeah, then
I think
that's,
I don't
yeah, it says it.
understand that.
Yeah,
Okay.
yeah.
And
that
I
covers
wanted
it.
to, yeah, the intent was to cover nurse practitioners and say that they can prescribe IV hydration therapy. And that
Okay.
whenever we mention practitioner in this document, they're included.
Yeah, agreed. Thanks
Okay.
for pointing out that sentence, Mike.
And what else? Well, another thing they wanted to add was right in that sentence, nurse practitioners to add advanced registered nurse practitioners. Just to make it a little more clear.
Mike,
So
is that going
in
to
that-
be their titles changing? Is that going to be the future title or the current one?
I asked them today, Micah. They said it's changing in 2026. So
So they'll all be
always
ARNPs at that time,
I don't know what it's changing to.
APRNs.
APRNs.
Advanced practice registers.
It makes sense in this context to have their appropriate designation, because nurse practitioner is more generic and can be interpreted in a number of ways. So having it an ARNP makes sense.
Would it make sense to put APRN with the anticipation that in 6 months this is changing?
Sure.
Right,
Yeah.
right.
Okay,
So-
a couple other
Mike, I apologize for interrupting. To Dr. Lyle's original point under legal requirements and best practices, sub 1, are we changing that?
No.
I mean, I appreciate Dr. Lyle's point here. Anytime you're trying to do joint statements from these four entities, there's always an element of kind of like, making sure we're recognizing each entity. And so, Dr. Lyle, to the extent that they're feeling like the practice of medicine isn't being used in a generic sense there, are we going to change that? to reflect their concerns? Or I'm sorry, I didn't know what the conclusion was there, or the consensus, if there was one, on sub 1.
This is Heather. Another option might be to add the nurse practitioner statute in the footnote you've got there too, that just has MDs and DOs. So maybe they'd feel more comfortable if you cited their scope statute, and that would include them better. I don't know. That's just an option.
Mhm.
I do think it doesn't belong in that sentence in that way, because it highlights them redundantly, but also it just doesn't send the right message about them. I think it's more appropriate that it be in a statement of scope of practice, as Heather was saying.
What if you, Mike, what if you said something constitute the practice of scope appropriate healthcare? Because I'm reading the statute for the nurse practitioners right now, and it says advanced registered nursing practice means the performance and acts of a registered nurse and the performance of an expanded role in providing healthcare services as recognized by the medical and nursing profession. So it's, when it comes to the definition, it's healthcare less more than it is medicine.
I like Heather's idea about making a very clear sentence in the footnote that nurse practitioner, maybe quote that statute, well, cite the statute, and then maybe quote the language, Micah, and make it clear that nurse practitioners can diagnose a patient's condition and recommend IV therapy.
Sure.
After 1871-011.
Dr. Lyle, does that address your concern?
Yeah, I just don't think adding a nurse practitioner to that sentence, I'm echoing what Claire said, that it doesn't make sense to me. So that's fine. Yeah.
I gotta say one other thing about this document, and I'm sorry I had not reviewed this one ahead of time. So I want to know, this comes from a place where IV therapy, at least historically in the organizations I worked in, where PAs got in trouble with this was infants and newborns, that there's an age beyond which it's very tricky and there's more expertise needed. And we actually had to, and policies and organizations I worked on, we had special age limitations. Do we have any in this? In other words, a baby that's 12 months or 14 months is a problem for someone with less training.
This is intended, Dr. Truscott, to address the issue of IV hydration therapy clinics or med spas or wellness clinics that provide IV hydration with minerals and vitamins and whatnot to help people feel healthier or more hydrated. Doesn't have general applicability to any situation, especially hospitals or clinics that have more traditional provide more traditional medical services. These are med spas.
But they would allow any of these practitioners to give IV therapy to any age?
I guess technically, yes. We hope they're using good judgment when they do this and not doing it on babies. Do you think we should add something?
Well, I do think there's an age range also in the very elderly. There can be some problems for people with heart disease. I just think there may be some limitation there around age would be an easy way to do it. And there's no saying who these people can treat anywhere that I've heard.
These are very general statements to provide some type of guardrails on practitioners, people who are doing this. Doesn't have the force of law, but it's guidelines to an area that's growing and there's a lot of unsafe practices going on. I have not seen, in all the research I've done, I haven't seen any reference to age. Doesn't mean we can't have one. I just haven't seen one.
I mean, I think it's okay to leave this as is and not change it, but this is the one thing about it that gives me pause. Because
Okay.
this can be a life and death kind of situation if you make the wrong assessment.
I can, if you have an idea for language, Dr. Truscott, if you could email me, I'm happy to put something in.
Do we anywhere describe the population that would be receiving this in this?
No, no, we don't.
So I don't know that I want to complicate it that much. You can tell me if this has no legal effects. I'm not sure we want to get into some of that. I'm just saying that historically in organizations I've worked in, we're very careful under a certain age.
So, Mike, is this more for those feel invigorated and feel, kind of wellness clinics that are springing up all over the place, vitamin therapy, come in and get, tons of vitamin B and you'll feel great. And
Yep.
Okay.
I mean, I would assume that they are
salons.
careful and they're treating healthy adults. But that's just an assumption.
I get where you're coming from, Claire. It does make you take pause, like who would they take in there? And I think these have sprung up a lot more and more where people are going in for hydration and vitamin therapies and all the wonderful IV things that they think are going to make them feel young and better again. So that's where I think this is going. But I hear what you're saying too about caution.
I suppose that all four of those categories would be aware of the dangers. In other words, the nurse practitioners, the PAs, and the osteopaths and physicians, that those groups would. So are they on premise then? Like the nurse practitioners there seeing the patient, examining them?
No,
Or they're just
no. Sometimes there are RNs on the premises, and they have standing orders from either an ARNP or an MD or a DO, and they apply the standing orders without any communication whatsoever with the person writing the standing order, with the practitioner. And sometimes
again, I'm sorry, that would be in the standing orders then. I mean, something about that most appropriately would be in the standing orders.
And standing orders is addressed in number.
I apologize for speaking when I haven't even read this. But
it's like 9.
No, it's okay. You've got those good questions, Claire. Concerns.
Number 9. And I asked the nursing board staff to bring this issue, to make sure their board sees number 9 and to comment on it.
So are we not voting on this today, or is this?
I wanted to talk about the process. This is a little bit unusual. So what I'd like is to have this go to the business meeting so the commission can come up with a final document, not a final document, but a draft that would then go to nursing, pharmacy, and osteo and say, this is the commission's draft. Because right now it's just the draft of the work group. And
I think, this is great. I think that it's just in this section, which again, I haven't read, I hate to be making comments, but one statement about appropriate ages to be treated in this setting would make some sense. You don't want them to be jamming also a whole bunch of fluids into a 90-year-old, or an 80-year-old. That's cardiac status isn't known. So, but definitely the infants or toddlers. So maybe
So what-
I can look at this, then Mike can maybe get something back to you, a suggestion about an add to one of these sections.
That would be great.
I'd have a younger person break off, for sure.
I think
I'm-
that I was going to talk about process. Go ahead.
I was just going to say on the standing orders on number 9, I mean, sometimes standing orders are reasonable to have in a practice to, you know, that there's things you do over and over again and it's easy to have a standing order. But I think what the intent of this number 9 means, it shouldn't be standing orders, standalone standing orders without a practitioner pulling the trigger on that. So I don't know how you wordsmith it. And I'm not sure it's necessary, but I just wanted to point that out.
So, Chris, I think that if the commission comes up with a draft that they're comfortable sharing with osteo nursing and pharmacy, those other entities, those other boards, are going to come up with their drafts, hopefully by the end of the month. Then I can bring them together back to you and say, this is what pharmacy wants, this is what nursing wants, this is what osteo wants. And then we can look at it again.
Okay. So are we bringing this? Go ahead. Go ahead.
I'm
Sorry.
sorry to interrupt, Chris. So
Okay.
Mike, essentially what we're looking for from the commission next week is kind of like an interim or preliminary thumbs up or feedback that we can then circulate amongst the boards. Just for the commission members, just as a reference, doing this, what Mike and Gina have been doing, kind of going back and forth between multiple boards, is incredibly time consuming and can be really draining. And so just as an aside, I wanted to say thank you to them again, because they both grabbed the reins and really took off. And this actually comes from FSMB's annual meeting that occurred last year, where they did a presentation about this, and Dr. Murphy and Dr. Domino were very concerned. But just as a preliminary matter, Mike, we're looking for kind of a thumbs up and then a final product when all the other boards and commissions we'll bring it back to the full commission. Is that the idea?
That's it.
Okay. So when we send out our packet, we can let the board know that we'd like them to take a little look at this one, make sure we look at this ahead of time, because we'll be asked for some input so that it's not just skimmed over, but we can ask for them to take a look at it and be prepared for some input at the meeting.
Yeah, I can add that to the email that I send out when the packet's ready for the meeting next week.
Okay, thanks, Amelia. And Amelia's had her hand up for like ever.
No, I just wanted to mention that in rule writing, we are getting away from he or she, and we're using they instead. That's something we've been kind of mandated to do. And
Okay.
so I think we should probably do that in any guidance documents or policies that we present to the public as well.
Okay, thank you.
Mike, you could just change that to individuals and they, and I think we're in good standing.
Yep.
Okay, so we'll point it out to the members and hopefully they'll come with some input.
I think Heather's trying to raise her hand.
Yeah, I just had a couple, like 2 comments, Mike, and I can give them to you later or today, but they're based on bullet points 18 and 19. I thought maybe contradicted each other a little bit. And then there's in bullet point 21, and then the very last sentence of the whole document, it seems to imply that, or not, I feel like it's endorsing some corporate practice of medicine that we maybe don't want to do. So those are my 2 comments. Like, look at 18 and 19 and see if you think they contradict, and then 21.
And are you referring to 21, Heather, or are you referring to the last paragraph?
Well, I think both of them are address the same thing. The first one talks about IV hydration clinics that aren't owned by a practitioner, which, is fine. But then then again, if you're a non-licensed retail therapy business owner, so I feel like those statements, I don't know if we want to encourage non-practitioner owned clinics, but that whole corporate practice issue is a huge problem. And it's complex and difficult, and we know it's happening. So
Yeah, I get emails from people saying, how can I'm a doctor and I know a layperson owns this med spa. What can be done? Can't you put a stop to it?
Yep.
So 18 and 19, just one of them says you can't delegate compounding, but then 19 says nurses can compound. So that's where I was trying to figure out how both of those line up.
I guess it depends on how you're
Set up.
defining compounding. They'll put like an antibiotic in an IV bag in order to give it to the patient as a common practice. Is that a compounding process? I mean, it's very common. And in fact, all this is a cocktail if they're putting in vitamins and other things into saline.
Yeah, I see the problem, Heather.
Yeah, and I'm not sure how to resolve that, but maybe a little more explanation or nuance. I don't know. Anyway.
Thank you.
And then I just had one more suggestion on this last sentence. If a non-licensed, they should contact any of the 4 boards. Is there going to be like a specific contact person for each board or commission in there? If not, then that's going to be difficult for those of us who answer customer service phone calls. Like, we won't know if they want to talk to someone on the nursing, who to send them to. I mean, obviously we can just send them to the main nursing number, but it would be nice to have an actual contact person for each of the boards and commissions that are involved with this guidance document.
There is a web page, a new DOH web page for aesthetics, which involves a lot of other things as well that the joint work group is working on. Informed consent, infectious controls, some advice for opening up a med spa. So this is just one of many documents, and there's a main document there, or if it's not there, it's about to be put there with names and contact information.
Okay, perfect.
But Heather just convinced me to take that sentence out.
All right, Heather. Shortening the document.
Dr. Lau?
I was just going to say, excuse me, on that last paragraph, you could just say questions regarding these guidelines, please contact the licensing board. Because that's what you're saying in both sentences, contact your licensing board or the licensing board. I think you could just make the sentence very generic. Please, any questions, please contact the licensing boards. And then you don't have to, you're not designating who owns the clinic, because that could just be people work at the clinic have questions, but they would know who to contact.
Yeah, good point.
Any other comments or questions? Hey, thank you, Amelia, for pointing it out when you send the packet out so folks can take a look at it ahead of time. Our last agenda item is the public comment.
So these are
Written
just
comments.
included
Mhm.
as
Go ahead.
informational. If you want to talk about them, you certainly can. It's really just, I mean, Dr. Funk had a response to what happened, some comments that were made previously, and then Dr. Bundy had a response to that. So they're just informational. They're not asking us to change anything. So you can talk about them if you'd like.
Anybody have any? I read them and I don't have any other comments myself, but does anyone else? We heard from her last meeting, if you were here, if you were part of the meeting.
I think we're good, Chris.
Okay, I thought people were reading. Is everybody good? Dr. Lyle, are you reading the document?
No, I
Okay.
reviewed it ahead of time. I'm
Okay.
fine. I don't have any comments.
Okay, thank you then. And I think that ends our meeting. Thank you also, Amelia, for putting in the plug about the interested parties meeting. If anybody is interested in joining that, the next one is scheduled for June 26th. And with that, I will adjourn the meeting. Everyone have a great evening and thank you for all your input.
Thank you.
Thank you, everyone.
Hi, all.
Bye.